Parotitis, the first, November 17th, 2024. Today we're going to focus a little bit on the etiologies or causes of parotid abscess. Parotid abscess is a complication of parotitis. Parotitis itself is inflammation of any cause, including infection of the salivary gland or the parotid gland. Parotitis can develop into parotid abscess in patients with risk factors, especially, that we will get into a little later. The most common cause of parotid abscess to develop is that it is a bacterial infection, most commonly resulting from ascending infection through the Stensen's duct or through bacteremia. So there is already an infection elsewhere and it spreads upward through the Stensen's duct, or a bacterial infection elsewhere in the body, doesn't matter how far it is from the head where the parotid gland is. Let's say infection in the foot. The bacteria can go through the blood barrier, travels through the blood of the patient into the parotid gland, causing parotitis, and then it can progress to parotid abscess. The diagnosis of parotid abscess itself is usually clinical. Sometimes radiological approach is also pursued, such as ultrasound and computer tomography. It needs to be noted that ultrasound sometimes cannot detect parotid abscess that are located deep. So the deep parotid glands, if they happen to have parotid abscess, if they develop parotid abscess, it is usually cannot be detected through ultrasound, but on computer tomography, especially if the computer tomography uses contrast agent, it can be detected. Drainage implementation is associated with longer lengths of hospital stay. However, this is just correlation at this point. There is no known explanation whether this is causative or just purely correlative. Because correlation is not causative, it can be that drainage implementation is done to more severe cases. So even if the drainage is not implemented, the length of hospital stay would still be longer than those without drainage. And the risk factors to develop parotid abscess from parotitis eventually boils down to impaired immune system and poor oro-dental hygiene. This immune system compromise can be caused by, let's say, diabetes mellitus and HIV. Although there are a ubiquitous amount of causes that can bring about impaired immune system, especially malnutrition, the presence of malignancy. By malignancy, I mean cancer, and other things that impair the immune system, such as transplant patients taking immunosuppressive agents to prevent their body from rejecting the transplanted organs, for example. In many cases, there is usually a dental focus, a dental infection that is undetected, that is accompanied by parotitis or parotid abscess itself, and therefore it is routinely recommended to refer for dental evaluation for patients with parotitis or parotid abscess because it's sometimes misdiagnosed or underdiagnosed. For parotid abscess that occurs in children in pediatric cases, it is recommended to follow up in a stricter manner along with a histological examination, that is, taking tissue samples and looking at it through a microscope, because there is a statistically significantly higher cases of tumor co-occurring with parotid abscess in children, and these tumors include such as parotid cysts and squamous cell carcinoma and adenolymphoma, for example. So histological examination is recommended in parotid abscess in children to exclude, especially for congenital parotid tumors that are present when they were born. Conservative treatment for parotid abscess include antibiotic regimen. This is usually recommended to be given for 10 to 14 days. Ideally, this is given after culture sample is taken and then readjusted according to antibiogram. Antibiogram is basically testing the bacteria that is found in the culture, is then tested which antibiotic is able to kill this bacteria efficiently enough. That's what antibiogram is. So once the correct weapon is found, then the antibiotic regimen is changed to that antibiotic. The surgical treatment that is used for parotid abscess cases include incision and drainage, and then followed by aspiration with or without radiology guidance, such as ultrasound. Further complications that can occur from parotid abscess include airway obstruction, because parotid abscess, the parotid gland itself, is in close proximity to the airway, such as the pharynx, and then a little bit below it is the larynx. And if the size is large enough, it can actually compress the airway, causing blockage, which is a medical emergency. Also, another structure that is close to the parotid gland is facial nerve. Facial nerve actually, in most cases, goes through the parotid gland in the face. Therefore, infection of the parotid gland, especially when it comes to the stage of an abscess, it can easily cause or spread to the facial nerve, causing nerve damage. It can also cause infection of the bone marrow especially, which is termed osteomyelitis, through direct invasion or through hematogenous spread. Hematogenous spread, basically, again, it spreads through the blood. So the parotid abscess, when the body detects an accumulation of foreign body, and pus is also categorized as foreign body or offending agent according to the human body, because it is full of debris, full of bacteria, full of dead neutrophils, full of dead leukocytes, other leukocytes. It is considered an offending agent, and the body will try its best to get rid of it. Sometimes in the form of, as you can see in some patients, where the skin overlying the abscess, the accumulation of pus, the pocket of pus, sometimes the overlying skin starts dying slowly, starts desquamating, starts peeling off like an acne, and then it pops and pus trickles down the abscess, because it is an attempt of the body to get rid of the pus. Sometimes this occurs not to the outside world. This tunnel formation to get rid of the pus sometimes occurs internally into the bone, especially nearby bones such as the jaw, therefore causing jaw osteomyelitis, whether it's the maxilla or the mandibula. It can also cause tissue destruction when the infection is severe enough or the bacteria is pathogenic enough. And if you have ever heard of the term flesh-eating bacteria, the medical equivalent of that, the medical term equivalent of flesh-eating bacteria is necrotizing vaseitis. And it can also further complicate into what's called mediastinitis. Mediastinitis is inflammation of any cause of the room that contains the heart, which is mediastinum. These, needless to say, can lead to severe consequences, and another complication would be septicemia, which is pretty much a term for infection of your blood, where the bacterial load or the amount of bacteria that circulates in the blood of the patient is very high. This is commonly accompanied with what's known as cytokine storm, which is where the immune system of the patient goes into panic mode and goes all-out attack on the bacteria, regardless of whether this also harms the body itself or not. An easier visualization of what cytokine storm is like is trying to kill a rat by storming a grenade into your house. So parotid abscess is basically a stage, a complication that results from parotitis where this infection is severe enough that it causes tissue destruction, accumulation of leukocytes, neutrophils, that then forms the pus material, the purulent material. This purulent material is those dead tissues and also dead leukocytes, which is usually packed with the causative bacteria. This usually results from ascending infection or hematogenous spread, as we had mentioned earlier, and due to its anatomical proximity to the facial nerve, it can easily also cause facial nerve damage. Appropriate treatment is necessary to prevent this condition from causing further damage and into more severe complications such as jaw osteomyelitis, airflow obstruction, facial neuritis, which is inflammation of the facial nerve, fistula. Fistula is the tunnel that the body creates to get out the pus, and other complications such as mediastinitis, necrotizing fasciitis of the craniocervical area, basically the head and neck. And temporal lobe abscess is abscess of the temporal lobe of the brain. Any abscess, any pathology of the brain can easily result in altered consciousness, somnolence, meaning the patient is harder to arouse, depressed consciousness, seizures, and other manifestations of central nervous system disorder. And the common bacterial causes of parotid abscess, the top three would be Staphylococcus aureus, Streptococcus, Haemophilus influenza, and in rarer cases, the bacteria include also Klebsiella pneumonia, Escherichia coli, and anaerobes. The risk factors eventually comes down to poor oral hygiene, allowing these pathogenic bacteria to outgrow the good bacteria, causing dysbiosis, and thus increasing the risk of infection in the nearby tissues. And also immunocompromise, such as in conditions with immunodeficiency, such as HIV, diabetes mellitus, obstruction of the ducts of the salivary glands, such as due to silolithiasis, that is salivary stone, or other causes such as tumor, swelling, etc. Dehydration also causes thickening of the salivary excretion, therefore increases the likelihood of salivary stones from forming, concretions, or hardened salivary excretion causing obstruction. Malnutrition also negatively impacts your immune system, therefore hindering your body from fighting infections. Therefore, infections are easier to develop. The treatment modalities include conservative management, that is antibiotics, and symptomatic medications when necessary, such as painkillers, etc. And more invasive procedures include surgical incision and drainage, followed by aspiration when necessary. And in this study, the samples that are gathered for this study are all patients that are diagnosed with parotid abscess via clinical or radiological diagnosis, that is ultrasound or CT, in the University Hospital Cologne and Munich from January 2012 to April 2022. Incision and drainage, and then systematic antibiotic care. And antibiotic is the standard of care. And then needle aspiration is performed with or without ultrasound guidance. And this is usually performed for abscesses that are up to 1 centimeter in diameter and without residual pus after the aspiration. For larger abscesses, usually aspiration is not performed because the drainage itself is already sufficient to draw out the purulent material for further testing. Drain placement is omitted when needle aspiration is performed or based on the surgeon's request. The culture results itself in the study were categorized based on their pathogenicity into highly relevant, possibly relevant, and probably irrelevant. Highly relevant are bacteria that are known to cause more severe infections. Possibly relevant is basically polymicrobial infection, multiple microbe that are showing up on the culture, but most of them are the normal oral flora. That goes into possibly relevant. And probably irrelevant is only normal flora. So it is a category where the pathogenicity is considered low, meaning it is likely that these bacteria that were cultured aren't actually the cause of the parotid abscess. This image is the depiction of parotid abscess under ultrasound and also under CT scan with contrast. The first row, the A and C image, is coronal view, meaning it is the view that you get as if you're facing the patient from the front. Under the skin, in picture A and B, which is the ultrasound imaging of a parotid abscess, you can see a cavity filled with hypoechoic substance and also hypoechoic debris. Hypoechoic means darker color and ultrasound. And you can see a little bit of encapsulation or hyperechoic features around the abscess, which may significate an inflammation that encases the abscess. And behind the larger abscess, you can see smaller pockets of purulent material as well. You can also see posterior acoustic shadowing, which is common when cysts or fluid collections are apparent on ultrasound. These dots, these dotted lines are things that you use to measure the size for reporting of these images. And on CT scan, these are of two different cases, mind you. So the CND is the CT with contrast, and it reveals these hypodense. Hypodense is basically darker color. These darker color pockets of purulent material along with capsular enhancement. So the edge of this purulent pocket is a brighter color, which is what we term enhancement, showing an encased purulent material with surrounding inflammation. This would be the varying causes of parotid abscess in this study. A majority of case is idiopathic, meaning the cause is unknown, and after further investigation, it still is uneventful. No cause were able to be determined. Mostly because this is a retrospective study, so it is more difficult to find out what the diagnosis is once it's a case that's already passed. And another majority of case also results from silolithiasis, tumor, and immunosuppression, and also a condition that has been going on chronically. And in 5.9%, there is a dental focus. And out of all the culture positive cases, meaning all cases that when obtained samples for culture shows up certain bacteria, out of the highly relevant or highly pathogenic bacteria. The top three is Streptococcus aeruginosus, Staphylococcus aureus, which is very common, Parvovirus micra, and the possibly relevant one, the top three include Coagulus negative Staphylococci, Cutibacterium agnes, and Candidas. Candida is actually a yeast, a fungi, not a bacteria. There is a unique feature of this study compared to other studies that have been performed on parotid abscess is that this study also show the presence of zoonotic bacteria in the culture positive cases, which is related to contact with wild animals. And these include Aggregatibacter acidophilus, Corynebacterium, Candida, Staphylococcus aureus, and Francisella tularensis. And also, currently, in this study, there were no data regarding whether antibiotics were given before the culture sampling or after the culture sampling. So it adds to the uncertainty and the quality of evidence, where the culture negatives may actually be false negative because they have been treated with antibiotic before the culture sample was taken. Ideally, antibiotic is given after sample for culture is taken. Therefore, the bacteria does not get killed before they are taken for culture. However, something that we can do to increase the yield of microbiological study, to increase the likelihood of we finding bacteria from the sample, is by analyzing the tissue sample instead of just the purulent aspirate, instead of just culturing the pus. We can culture the tissue taken from the parotid abscess. For the main antibiotic regimen, usually what's implemented is aminopenicillin plus beta-lactamase inhibitor, and for atypical cases or suspicion for anaerobes, sometimes clindamycin plus a third or fourth generation cephalosporin is also given. This regimen is recommended for 10 to 14 days, and ideally it is readjusted according to antibiogram, meaning these are initial antibiotics because it has wide coverage. It kills a lot of types of bacteria. Once antibiogram results show up, meaning we know what more specific weapons can kill these bacteria, we readjust the therapy to one that uses the more specific weapon. Why do we want to be as specific as possible in the weapon, that is the antibiotic that we use? Is that wide coverage antibiotic like this can be used for empirical coverage, for empirical treatment, meaning it's a treatment that kills all sorts of bacteria. But therefore, the bacteria will grow resistance by some chance. It increases the likelihood of them being resistant to these mass destruction antibiotic. We don't want that. We want to use empirical antibiotic as sparingly as possible. So ideally, antibiogram is performed. However, it is sometimes not feasible cost-wise in low to middle income countries. And it also needs to be noted that sometimes cases are actually resistant. The bacteria are actually already resistant to the empirical coverage antibiotic. So antibiogram will usually show that they are only susceptible or sensitive to higher level antibiotics that are reserved for more severe or more resistant infection, such as vancomycin, let's say. It's a next level antibiotic, you could say, for superbugs, for bugs that are resistant to a lot of antibiotics, including the wide coverage ones. Parotid abscess can occur at any age, but predominantly it occurs in the 4th to 6th decade of life, that is 30 to 60 years old. And overall, in this study, 14 patients 40% of patients have immune compromise. However, their immunocompromised status does not affect the clinical course, meaning those with immunocompromise versus those without signs of immunocompromise, they don't have statistically significant difference in their clinical course. And this is a more elaborate version of the risk factors for parotid abscess, which, as we have mentioned, it include poor oro-dental hygiene, autoimmune disorders. Autoimmune disorders are conditions where your immune system attacks your own body. It is treated with immunosuppressive agents, therefore it also reduces your barrier, your defense against infections. And it also comes with an inherent impairment to your immune system most of the time. Ductal or parenchymal disorders, basically disorders such as obstruction, which may result from tumors, swellings, or salivary stones. Superinfected adenolymphoma, this is an example of a tumor case, and then the tumor gets infected, which is termed superinfection. This is a risk factor for parotid abscess to develop. Specific disseminated disease such as melioidosis and tuberculosis. Tuberculosis itself, as you might have heard before, tuberculosis is caused by Mycobacterium tuberculosis. This bacteria is a slow-growing bacteria and is present in almost everyone alive today, but it does not cause disease until the immune system is impaired. So after that, the tuberculosis bacteria will cause a disease. So tuberculosis itself can be used as a marker of impaired immune system. And then immunodeficiency itself, which occurs in patients with uncontrolled or untreated HIV and diabetes mellitus. Diabetes mellitus causes immune impairment mainly through free radicals that is generated by the hyperglycemia. HIV by impairment of lymphocyte proliferation and function. It is very common that parotid abscess occur with dental focus, and it also predisposes the patient to a longer hospital stay and therefore higher cost and higher rate of complication, especially nosocomial infections. So it is routinely recommended to refer parotid abscess patients for a dental examination. In children cases of parotid abscess, there's also a higher propensity for a tumor to co-occur, to coexist. And these include congenital parotid tumors, such as parotid cyst, let's say, and also malignant tumors, such as adenolymphoma and squamous cell carcinoma, for example. They are all malignant tumors, except for the parotid cyst. And therefore, for children or pediatric cases of parotid abscess, it is recommended to obtain histological examination. And when it is compared between surgical interventions with general or local anesthesia, it shows that there were no significant difference in outcomes. Therefore, general or local anesthesia for the surgical intervention of parotid abscess are equally safe and effective. There's no difference in the complication rate nor the recurrence rate between general or local anesthesia. Out of these two hospitals that are used to gather the samples for this study, one location, one hospital has a longer duration of antibiotics, but it is because of the differing standard of care. Instead of an inherent difference between the patient characteristics between the two hospitals. This shows that there's a lack of optimal standard of care for the treatment of parotid abscess as well. So it's an opportunity for further research. The treatment for parotid abscess commonly involves surgical intervention, that is, incision and drainage, and then aspiration is done with or without radiological guidance when drainage is not performed. Drainage itself, as we have mentioned, is associated with a longer hospital stay. However, this is a correlation, not necessarily a causation. However, in this study, patients that were not put on drainage, they did not show a higher number of complication, nor recurrence, nor the need for a longer antibiotic regimen. However, this can easily be a false negative because the sample that does not undergo drainage is too small. Only 2 out of 79 cases. The limitations of this study, that is, this study has not considered whether antibiotic treatment was started before culture or after culture. So this adds to the uncertainty of the culture negative cases. They can actually be culture positive, but it has false negatives because antibiotic was already started before the culture sample was taken. And it does not take into account the abscess size nor the overall patient's condition for the surgical intervention. And also, it does not consider ultrasound negative cases, meaning less severe cases or cases that occur deep in the tissue, such as deep parotid abscess, that is sometimes undetectable through ultrasound. And less severe cases where it is not treated surgically but treated conservatively with antibiotics and then resolved and thus does not progress to surgical intervention. These were not taken into account in the study as well. So whether antibiotic treatment is efficient or effective and how effective it is for less severe cases is currently unknown because they are not part of the sample. Thanks for watching.